Now, so we have realized that we have to look at the distribution pattern and we have to look at the morphology of the calcifications. Now, let's put this information together and look at a few cases. Now, this is a 59-year-old lady who has a right breast hemorrhagic discharge, right? Now, just to confuse the picture, you also have densely calcified vessels in her. So when we, blow up these images, what do we see? We see these segmental distribution of fine pleomorphic calcifications. Let me show you again. These are again, in a triangular manner, and they are basically with the apex of the triangle located towards the nipple. So here you have a morphology that is suspicious. You have a distribution, the pattern that is suspicious, which increases the positive predictive value of the fine pleomorphic even further to more than 60%, makes it a BI-RADS 4C, and of course you biopsy these. And just wanted to point out that when we did her ultrasound, we did find a few thick walled ducts. So as usual, you just want to kind of do something that is not correct, but do something that is really, patient was not willing to come back for a stereo biopsy. So I said, "Theek hai, chalega, let me do an ultrasound guided biopsy." So we went ahead and did that. And of course, we did not get anything. We did not get like a positive diagnosis for DCIS. And this was obviously abnormal. So we kind of convinced her. She came back after a few months, actually. And we were able to then kind of convince her for a vacuum assisted biopsy, which showed that this was a DCIS of the high grade. So just a word of caution when you're kind of doing an ultrasound guided biopsy, that, if there is a radio pathological discordance, then, at least we kind of follow them up and, make them come back for a proper biopsy that is mandated, as in this case, it was a stereo guided biopsy, right? Now, this is a 67-year-old lady who came for a screening, and she was an anxious patient. She was referred for biopsies now from outside. And what did we see? We saw basically groups of coarse heterogeneous calcifications, which were bilaterally scattered. And there was actually, I didn't know what to biopsy. So morphologically, there was coarse heterogeneous calcifications. The distribution pattern was also kind of quite bilateral. And so both were less concerning. So we gave her the option of just a follow-up, but she wanted to go ahead and do a MR. So we did an MR to placate her. And obviously there was nothing that was enhancing in either of her breasts, right? Now, just a companion case to show you that coarse heterogeneous calcifications, when we see them in what we call as a segmental distribution. So now here you have coarse heterogeneous, which are, of intermediate concern, but here you have a distribution which is, worrisome to you. Then you go ahead and biopsy these calcifications. And this turned out to be a fibroadenoma with usual ductal hyperplasia. And it didn't look like a fibroadenoma on ultrasound, right? Let me just tell you, it came out to be fibroadenomatous changes with usual ductal hyperplasia. Now, this is a 32-year-old lady who has come for, her routine screening, because now she's treated case of right breast cancer, and now she wants to, have children, go for IVF treatment. So her doctor sent her for an evaluation. Now, you really don't see anything much on the 2D views. So what we had to do was actually do a magnification view to see these bunch of calcifications. So now these are basically more than, 4 or 5 calcifications, which are grouped. So they are grouped calcifications. But what are these? These are new calcifications. They were not seen on when we had her serial follow-ups. So new calcifications, these are fine pleomorphic. They are in a group distribution. Obviously the morphology is extremely suspicious. And even though we just go ahead and biopsy all, morphologically suspicious newly appearing calcifications. So that is the dictum, right? So this is what turned out to be a high-grade DCIS with commodore necrosis. Now, this is a 40-year-old who came for a routine baseline screening mammogram. And what did we see in her mammogram? We saw that she had multiple punctate, round, few coarse heterogeneous calcifications, but how were they distributed? They were distributed in a segmental manner, and they were distributed exactly along her 11 to 12 o'clock ducts, right? And so the morphology here was punctate, amorphous, and coarse. but the distribution was worrisome. So even though these were of intermediate concern, we said, let's go and biopsy this. And luckily for her, it turned out to be just a focal fibrocystic change, and there was nothing else in for her. Now, this is a 44-year-old lady who recently noticed a lumpish feeling from the right breast and serious discharge. So, what do we see? We see these calcifications, which are, fine pleomorphic. A few of them, if you notice, are also showing you what is called as the linear branching pattern. So, these are fine pleomorphic and fine linear branching. So, obviously, a suspicious morphology. And the distribution, of course, is also segmental and suspicious. Okay, so no brainer, we go ahead and we biopsy these, right? Now, in her, what happened is that we didn't have actually a focal mass. There was a diffuse heterogeneous area, and we went ahead and did an ultrasound guided biopsy. So just one thing to add is, even when we do an ultrasound guided biopsy, if microcalcifications are the concern for us, and then we do go ahead and basically take a magnification view of the samples to see that we have tackled and got a few microcalcifications in our sample, right? And this turned out to be again a high grade DCIS. Now, these are cases where patients are post-op, and so you see these. This is a 47-year-old lady who was status treatment many years ago, and on her regular follow-up, you see all these weird kind of very irregular, ganda looking calcifications. And another patient who was 65-year-old, again, with very hard palpable lump, but these are all dystrophic calcifications which you see in the lumpectomy site or at the place where the patient has been irradiated. And you just have to know that these calcifications, nothing needs to be done. These are benign calcifications, and you just tell the patient to go back onto a regular follow-up and follow up these calcifications, right? Nothing needs to be done.